Hello everyone, welcome to Mid Adventure. In today's episode, we'll be having a discussion on a case report published in Journal of Medical Case Reports. Before going to the discussion, this video summarizes a published case report. I do not claim authorship or credit for the original case. Patient details have been de-identified, and these are the medical advice. The title of the case report is Life-Threatening Complications of Retropharyngeal Abscess in an Infant. The objective of this presentation is to learn the clinical signs and symptoms of retropharyngeal abscess and see the importance of multidisciplinary management and the management options. The case report is on a previously healthy 10-month-old infant who presented with fever, right-sided neck swelling for 10 days, and hoarseness of voice with respiratory distress for the past 3 days. On physical examination, the patient is febrile, tachycardic, has bilateral neck swelling prominent to the right lateral side. He also has stridor and increased work of breathing. Laboratory workups revealed leukocytosis with left shift and elevated CRP. Neck ultrasound showed bilateral cervical lymphadenopathies. Then the patient was started on antibiotics and intubated in the OR guided by video laryngoscope by anesthesiologist. He was then put on mechanical ventilation and transferred to the pediatrics ICU. CT of the neck was done and showed a large rim-enhancing fluid collection in the retropharyngeal space with extension into the right paravertebral space with surrounding inflammatory changes and cervical lymphadenopathy. After the CT results, the patient antibiotics were changed to broad-spectrum antibiotics, including ceftriaxone, vancomycin, and metronidazole. Then, ENT specialist was consulted for endoscopy-guided abscess drainage. About 5 cc of abscess was drained, and culture revealed enterococci and candida. Then, antibiotics was de-escalated to amoxicillin clavulanate, and fluconazole was added. Blood culture was done twice and both were negative. The patient was extubated on the second day. Feeding was resumed via NG tube and gradually breastfeeding was started on fourth day. Then the patient was discharged on the fifth day and he was doing well upon follow-up 1 week after. Now, let's have a few words on retropharyngeal abscess. Retropharyngeal space is the space between buccopharyngeal fascia and prevertebral fascia. So, retropharyngeal abscess is an abscess collection in this space. It's more common in children under the age of 5, and upper respiratory tract infection and odontogenic infections are the most common causes. Delayed diagnosis can lead to life-threatening complications such as mediastinitis, cavernous sinus thrombosis, and rupture of the abscess in the trachea or pharynx. Retropharyngeal abscess is polymicrobial, therefore it requires antibiotics effective against all potential pathogens. CT scan determines the extent of the abscess and involvement of adjacent structures. It's also helpful in surgical planning. Treatment option for retropharyngeal abscess can range from intravenous antibiotics to surgical drainage. Surgical abscess drainage is indicated for patients with abscess measuring greater than 2.5 cm on CT, or use of empiric antibiotics up to 48 hours doesn't result in any response. The surgical approach depends on the site of the abscess. External approach is preferred for superficial abscess and if the adjacent vital structures are displaced medially. Intraoral approach is the safest and has low morbidity, lower hospital costs, and avoids neurovascular injuries. In this patient, the abscess was measuring greater than 2.5 cm and the patient was symptomatic. Therefore, endoscopy-guided abscess drainage was done. However, if the patient had presented with abscess measuring less than 2.5 cm and was not symptomatic, he could have been managed with only empiric antibiotics. Empiric IV antibiotics should be started as soon as possible and must include penicillin combined with beta-lactamase inhibitors and anti-anaerobic antibiotics like metronidazole or clindamycin. The antibiotics can be adjusted after culture report. In summary, due to the unique anatomic structure of infant airway, a small amount of edema in the airway can lead to significant airway obstruction in infants. Intubation can be difficult and anesthesiologists and otolaryngologists should be involved to secure airway in a controlled setting. Therefore, management of retropharyngeal abscess is a multidisciplinary activity involving intensivists, ENT specialists, anesthesiologists, and infectious disease specialists. And remember that exams like CT should only be done after airway is secured. This will be all about the case report. For more information and imaging results, I recommend you to read the case report. Thank you guys for watching this episode. I hope this case was interesting. Please don't forget to like, share, and subscribe for more.